everybody. My name is Angela. I work at UMass Memorial Health Harrington. Thank you. Thank you for being here. We've been trying to put together some education series to give people a little bit of education about a whole bunch of different things. This is our third one. Dr. Stan has been kind enough to offer to put together a presentation for us tonight. He's going to be talking about different urologic conditions. Dr. Stan has been with us since this spring and is already doing amazing things and bringing in all sorts of fun new technology to our community. So we're super excited to have him. With no further ado, for you, sir.
Thank you. Appreciate it. Some familiar faces out there. So tonight we're going to talk about two things mainly. We're going to talk about BPH, which is benign prostatic hypertrophy, which is basically non-cancerous growth of the prostate. And additionally, we're going to talk about incontinence. So the first thing we're going to talk about is BPH, and we'll start with this slideshow here for you folks. So basically, what's the importance of your prostate? So your prostate basically for men makes semen and it allows for the ejaculation fluid. You can switch that over for me. So basically it's a walnut-sized gland at the base of the male bladder. So you can see that where it says prostate, the orange gland there. So basically you're talking about walnut like this. So what happens is that over time, the prostate can grow. And we're going to talk about it in a few minutes. But basically, as I was mentioning, it transports the sperm during ejaculation. The urethra runs through the middle of it. So it's basically like a donut. So if the donut's open, your flow is good. If the donut's closed, it's not so good. So if we move on to the next slide. So we talked already about what BPH is, or enlarged prostate. It's benign enlargement, non-cancerous growth. Additionally, you get prostatitis, which can either be an infection or inflammation, and that's treated totally differently, and that's a short-term problem. It's not a long-term problem. Prostate cancer, extremely common as we age, but typically it's slow growing, and usually for a lot of people it can be monitored. Some people need treatment, but that's a whole nother story and another presentation. So if we move on to the next slide. So as I mentioned, your prostate grows. So you can see that at age 1, it escalates until basically hit puberty. That's when you have basically a walnut-sized gland. When you get out here to age 75, the prostate is much larger. So you may see prostates that are a grapefruit, not a walnut anymore. And the urine has to go through that to get out of the bladder. So with that back pressure, what happens is that the bladder has two functions. One function is it needs to expel urine. Second one, it has to hold or contain urine. So just like if I was sitting here working out and I actually had muscles, I would be good at lifting things. The bladder, as it works out, because of the resistance that the prostate causes, the harder it has to pump against the prostate, the thicker it gets. So as it gets thicker, the capacity that it can hold becomes less. So it becomes very good at expelling urine, but not so good at holding urine. You go to the next slide. So as we mentioned, this is basically what you might see for a percentage of men with BPH. And you'll note there's 42 million in the United States. It's because basically every male, if they live long enough, is going to have a prostate issue. So it's 60% at age 50, 70% at age 60. At age 80, it's 90%, 80% at age 70. So it's a very, very common problem. And most people try to overlook it. Go to the next slide, please. So I mentioned this already to you. This is a non-cancerous enlargement of the prostate. You can switch over. So this is an idea of what's happening here. So we've got a normal bladder on this side. We've got an open prostatic fossa. The opening goes right through the prostate. Like I said, this is sliced in half. So it's basically, it's going to be rounded otherwise. And then if we look at obstructing, or when the BPH starts to grow, it basically starts blocking off the obstruction in the urinary flow. And we get what you can see, those lines, those are thick muscle bands. And like I mentioned before, if those become thickened, you can't contain or hold urine very well. You have a lot of frequency, urgency getting up at night. So you can go to the next slide. So as I mentioned, weak flow, incomplete elimination of urine, stopping and starting a flow, sudden urge to urinate, getting up at night. So getting up at night is a big one. You can see 64% of women are affected by their partner's symptoms of an enlarged prostate. So you can go on to the next one. On the left is a normal bladder. It's smooth. We look at as things progress, as the prostate gets larger and the resistance increases, the bladder starts to worsen and you get these fibers that are becoming thickened. Then if we go all the way over here, we get this problem. This is a thickened bladder. Those are muscle fibers that you see there. But more importantly, what you're seeing is those divots that are there. Those are called cellules. And what's happening is the pressure is so high inside the bladder that the lining of the bladder is starting to push through the muscle fibers. And that causes permanent damage. So if you're coming to see me and you've got this, there's not a lot we can do. That really resides on having a catheter or a suprapubic tube, but treatment sometimes is not going to fix that. So go ahead. So what do we do to diagnose BPH? So we obviously take a medical history. We look at an IPSS score, and there's actually a pad in the back there that has, you can score yourself for the men, and you can see where you line up. It'll tell you if you have minimal, moderate, or severe symptoms. And the real question is, does it really bother you? And a lot of men are really good at saying nothing bothers me, so I'm just going to continue on. So the other things we can do is we can do a uroflow, where you can measure the flow of your urine and determine if there's an obstruction. Rectal exam, bladder scan to see if you're emptying completely. Pressure flow studies are a little bit fancier than just a uroflow. It's combined to see if there is a problem with the pressure or whether there's a problem with the flow. And then we can do an ultrasound of the prostate, transrectal ultrasound, with or without biopsy. If you have elevated PSA, one of the things we want to know, is this obstruction caused by cancer? So that we might want to figure that out. If you know your PSA is elevated, we may want to get a biopsy before we just assume that it's an enlarged prostate. And then quite often, or most often, we look into the bladder with a scope so we can see what we looked at before. I can see those muscle fibers. I can tell you, well, you've got these heavy duty muscle fibers in here. You've got an obstruction, and show it to the patient on the screen. And that really makes a big difference in them understanding what the problem is. If you think about it, there's two organs in the body that contain fluid and are basically hollow. One is the heart, has 4 chambers. If you have high blood pressure and your heart has to work harder and harder to push the blood through, it becomes thicker and thicker. You end up getting congestive heart failure, or heart failure in general, because it can't push anymore because it's worked up and it's so thick. Same thing with the bladder. Bladder has the same problem. It's not 4 chambers, it's only 1 chamber, but it gets thick and it doesn't function well if it gets thick. So this is the IPSS score. You can see 0 to 7 score, mild, 8 to 19, moderate, 20 to 35, severe. So we also measure quality of life to determine how bad it's bothering the patient. So treatment options. So there are a lot of treatment options out there, and there seem to be more and more coming all the time. So I've been doing this for about 30 years. So I was doing green light lasers back in 1993. That was what we thought was going to be a great thing. However, the lasers I was using did not have the wattage necessary needed to remove the enlarged prostate. It only had enough to ablate it or kill it. And then the patients would have this dead prostate inside them and they'd be miserable. So I would have to go back and actually resect them. So that didn't last very long. So we moved on to different technology now, and we can look at this from across the way. Watchful waiting, most men do that. They say it's going to get better. And the thing to know about BPH or enlarged prostate, it's cyclical. So that for a little while, it's going to be great. It's going to be fine over here. So it's not so bad. I can deal with that. And then it's going to start to ramp up and go, oh God, maybe I ate something. I'm not sure what's going on here. And then it starts to slow down and comes back down and you're a little bit better again. And so if you're taking beta prostate X or some other kind of over-the-counter medication, what often happens is that you start taking it when you're feeling bad, and then just naturally the prostate gets better, and then it goes back up again. So there's a lot of people that say, wow, this really worked for me. I'm going to keep taking it, even though their symptoms continue to wane and wax. So if we look at medications, back when I first started, the only thing we had was saw palmetto. And then the first medication was Proscar, which basically increases your estrogen and decreases your prostatic size. It's supposed to take 3 to 6 months to work. It's not very effective. at this day and age, I wouldn't suggest that anybody needs to be on that. The next thing we have are alpha blockers, and alpha blockers work by relaxing the prostatic surrounding the cavity that's in. So if you've got a prostate, you've got a lining around it. So the lining itself, or the capsule of it, is not stretchable. So as the prostate tissue increases in size, it's contained, and so it starts to squeeze down. So when you take Flomax as an example, or tamsulosin, what happens is that it relaxes the capsule. So that allows for some expansion, which in turn allows for the urine to come through a little bit easier. And quite often that's enough for men to go for quite some time. I just saw a gentleman in my office today. He's got a bad bladder. He's been on tamsulosin for 15 years and it's not working anymore. It stopped working probably 8 years ago, but he was still taking it. So people start taking it. You just have to realize that it's not something that's going to hold off the enlargement of your prostate forever. Your prostate's still going to grow. This just gives you some more time. Now we can look at procedures. Urolift is one that we do. There's one that's called water vapor or steam therapy, where you actually put steam in the prostate. I'm not a fan of that. I used to do a procedure called the tuner procedure, where we actually put antennas from basically a microwave inside the prostate and try to kill the prostate tissue that way, which is very much what water vapor is doing. And it was not a very good solution because it was patchy. You get some areas that really went away and some areas that were still there. And also, once again, you have the necrotic tissue inside your prostate, and that's all got to be reabsorbed. So what I tend to do for small prostates, and that's up to approximately 60 grams, is do a Urolift. And there was a little more information because this is a Urolift presentation. The other thing that I do is lasers over on the end here. Lasers can be used for a lot of different problems. Prostate anatomy comes in different flavors, if you will. You can have two lobes coming together, or if we're sitting in your prostate right now, you can have an extra lobe called the median lobe that comes back and forth. So as you urinate, it pushes forward and blocks everything off. Then you relax, it falls back, you can urinate again. So that isn't treated very well with Urolift. It can be in small areas, but isn't the greatest option. Laser gets rid of that tissue right away, and that really solves the problem if that's the issue. So go to the next slide, please. So this goes through the different things, and as you can see, this is a Urolift presentation, so they've got all the checks. So, but it is a very good system, and it does very well. Go ahead. So this is what I do for a Urolift. There's a prostate on the left side. You notice that there's no opening going through the middle. That's my telescope looking at in the second slide. And we're looking in there to see what we need to do. So the prostate is kind of spongy. So what you can do is push the scope over and basically shoot out a staple. It's more like a, I guess we just call it a staple for now. It locks onto the outside of the prostate, and then these sutures are basically shortened up, and that pulls the everything apart. Oh, I'm sorry, toggle bolt. It's very much like a toggle bolt. When you shoot out, just like if you're hanging a picture in drywall, it goes through and opens up on the other side and locks it in. So you can go to the next slide. So this is about the size of this procedure. This is a little staple. You can see that it goes straight out, then that little bottom kicks open, and that's the toggle. So it's a very small device. Usually we use about 6 of those to get everything opened up. It takes about 15 minutes to do the procedure. It's done as an outpatient under IV sedation, and you go home the same day. Next. So this is, and I don't think we have this. So this, once again, this is, what we're real life. So here's your prostate. It's tight together. After the lift procedure, you can see that now we have an opening going into the bladder so that the urine can come out easier. So this just tells you what to expect afterwards, which we really don't need to get into right now. And as I mentioned, it's covered by Medicare. So this is Jim Ward. The Urolift system was a game changer for me. My wife was right that I should see a urologist if I didn't have to keep living with my bothersome BPH symptoms. So the suggestion is to take that score on the back, and if you like my cards up there too, I'd be happy to see you with that. So the next questions? We'll hold questions till the end. So this is Ed.
When you first start having the problem and you gotta go, the worst part is you stand there and you can't go. I'm 62, really active, I take really good care of myself. There was really no easy solutions. But it happens to be a urinary tract problem that could ultimately lead to an erection problem or a sexual dysfunction problem. Everybody says, welcome to the club, and I don't want to be part of that club.
Ed's always been full of energy and larger than life. When I noticed that he was not the same, I knew that the BPH was causing him a big problem. He just wasn't as engaged.
BPH, benign prostatic hyperplasia, essentially is an enlargement of the prostate. And in simple terms, when it starts to get enlarged like that, you can't go pee. When I laid down, it seemed to put more pressure on my bladder, hence I would get up almost every hour on the hour. You can imagine what it does to your sleep. I mean, literally towards the end, it became just like having a bad nightmare. And I find myself getting a severe lack of sleep. Well, that affected my mood, my stress levels. It seemed to cause me constant worry because it was always on my mind.
When the person you love starts to change, it's an unsettling feeling. It started to affect things that we were doing. I mean, intimacy has been a really big part of our relationship, and that was definitely affected.
But ultimately, you kind of mask over what's going on, and I think we try to kid ourselves that I can deal with this. But once you get into a medium to severe BPH problem, you really don't have much choice. You're going to have some type of surgery. The meds don't work at that point. I did all the research possible. I mean, I went on every website, quizzing the doctors, and I found out that there's probably 3 or 4 different procedures. They all have potential side effects. And in men's health, I don't think this is something anybody should fool around with. I really didn't want to compromise. When I came across the aquablation, I realized that I didn't have to make those compromises. All I had to do was make the choice. For me, it was a no-brainer to go forward with the aquablation.
The procedure overall was quick. He didn't have any complications.
I could not believe the result that I had. It was immediate. I forgot what my real freedom was like. I had no problems, no side effects from a sexual standpoint. And it's just amazing that I don't think about going to the bathroom anymore. It was like not only just treating me, but treating my life, my lifestyle. It gave it all back to me again.
Now he's back to his old self. It's actually changed our relationship for the better. It's just completely different. And we've completely reconnected. I'm really grateful for that. I have my best friend back. You don't have to grow distance in your relationship because of something like BPH. For anybody out there who's going through similar things, I would not hesitate to look into this procedure.
It's so different now. I mean, to say it's a 180 is an understatement because once you've been on both sides of it, it's life-changing and life-altering. It's freedom. Boy, let me tell you, I made the right decision.
Great. So that leads us into our discussion about aquablation. So a couple of things are happening over at Harrington. One is that by the end of this month, beginning of next month, we'll become the only center of excellence for UroLift procedures in Massachusetts. So the first and only, so that's great. The other thing that the hospital allowed me to do was to purchase some additional equipment. And the equipment we purchased is called aquablation. So aquablation is a different type of procedure. It's done with a robot. So the equipment itself costs $500,000 to have it. And what we do is we do an ultrasound of your prostate and we map it out. And we give it to the robot. And the robot, just if you know about those people that cut things out of metal and they have that plasma cutter and it goes all over and cuts out whatever shape you want to, it's the same idea, but this is using water pressure. So if you think about using a pressure washer, if you get the really fine spray down a stream like, you don't want to put your hand out there and check it up because it's going to take the skin off your hand. So the aquablation is basically a small water pressure, and it adjusts the height, width, and everything else based on what I draw out as the plan for that prostate, because every prostate's a little bit different. And then it goes for about 5 minutes, whoosh, 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 all the way down the tip, and then comes back one more time and does it again. At the end of that, basically the prostate tissue that I want out is gone. So then I look back in and then I coagulate any bleeders. And the patients generally stay overnight, one night, just to make sure there's no bleeding. There's no sexual issues with that. Some of the things you can do for the prostate can cause what's called retrograde ejaculation. What that means is that the semen is no longer going out through the tip of the penis. it's actually going back into the bladder because the bladder neck doesn't close. When you ejaculate, the bladder neck closes and the ejaculatory ducts in here shoot the semen out. So if this doesn't close, generally speaking, the distance between here and here is longer than here to there. So the resistance allows for everything to go backwards. It doesn't cause anything with any sexual dysfunction. The same thing with Urolift, it doesn't do that at all. Lasers can cause issues with retrograde ejaculation. But it's a really nice procedure. It's going to remove most of the prostate tissue, which is much better than anything else can do. Even us doing what's called the old rotor-rooter job does a better job than that. It does a better job than what's called a simple prostatectomy, because when you get to those grapefruit-sized prostates, you're looking at how do you get rid of that tissue, and you need something that's going to get rid of all of it. So what we usually do is called a simple prostatectomy. Make an incision and open up the bladder. Once you see the prostate, you dissect around and try to remove all that tissue out. But that comes at an open procedure. There's a lot of bleeding with that procedure. And you also can get incontinence with that procedure if you go too far trying to take out that tissue. So this allows us to take care of any size prostate, whether it be 150 grams like a softball, or whether it's a melon. Whatever you got, it'll take it out. So we're very excited about having that as a option for patients. So that takes care of the BPH aspect of this talk. So now we're going to talk about incontinence. So basically, there are two different types of incontinence. One is urge, and one is stress. So urge is pretty simple. You feel like you need to go to the bathroom, can't go, you walk around and all of a sudden it goes on you. You get the urge, but you can't get to the bathroom in time. So that's urge incontinence. Stress incontinence, on the other hand, is if you pick something up and you leak. That's stress incontinence. So they're treated completely differently. Urge is primarily medical. Stress is primarily surgical. However, we're going to talk about new things here, so what's available. So for urge incontinence, what can be done is sacral nerve modulation. So if you've tried medication, most of the medications cause dryness of mouth. Some can cause high blood pressure. Some can cause constipation. So if you have that issue and the medications aren't working for you or the side effects are not what you like, we can do sacral nerve modulation. And what that involves is basically modulating the sacral nerve 3. So sacral nerve 3 comes out of your tailbone, way down here. And it controls the bladder and it controls the bowels. So this procedure actually works for bowel incontinence as well as urinary incontinence. So with you lying flat on a table in the operating room, we numb up your skin, and I use an x-ray to find the nerve by looking for a nerve response. Once I find the right response, I put a little wire in your skin, and then we tape it all down, and you have a little battery pack that you wear for the next week. And if it works for you, it's like turning the lights off in this room. It'll be amazing. You can't believe it actually worked. If it doesn't work for you, which is 20% of the time, we simply take the wire out of your skin. So it's a test. You don't burn any bridges. There's no issues. If you pass the test and you're going to want this placed, and basically it's the same as a little cardiac pacemaker battery that you put up here. This just goes right here on your rear end. And that works for the next 10 to 15 years and controls your bladder. It's a great procedure. I started doing these in 1995 as the first person to do them in the Northeast. I've done a lot of them. I used to be a trainer for the company and putting them in and training other physicians how to do it. So I like the procedure. It's unfortunate, it's very different. I just came back from Florida. I was in Florida for a year and a half during COVID because they were open for business down there, and down here you couldn't do elective procedures around here. So I went there, and my brother has also a urologist down there, so I joined him for a little while. But there's a total different mindset between Florida and Massachusetts. So in Florida, people get procedures done. So I did a lot of sacral nerve modulation in Florida. I also did a lot of urolifts. I think I did 200 and something the year and a half I was there. maybe close to 300. It's actually kind of funny. I saw a patient of mine who told me that he wanted to get a UroLift, but he couldn't find anybody that did it in Massachusetts. And he said he's from Florida. And as we talked a little bit about it, he goes, yeah, down in Florida, you can get a UroLift at a 7-Eleven. Everybody's doing UroLifts down there. But so it's definitely a different mindset between the two areas. And so I think for people, especially in your age group, my age group, that you need to think a little bit outside the box and say, oh, we're very conservative up here in New England. We don't really want to do too much. But if it can change your life, which all these procedures can do, you only have so much life left. And I look at that all the time when I think about what's going on in my future, that you want to at least be happy, you want to be healthy, and you want to be able to do what you want to do. If you're leaking urine all the time, if you're running to find a bathroom, you're not going to be able to do that. So it's very easy procedures, they work great, and they really should be considered. The last thing I'm going to talk to you about here is stress incontinence. So stress incontinence, generally, that's where the bad mesh problems came from. Everybody's complaining that they got mesh and it was infected and did all these things. So generally we use a surgical piece of mesh. Notably, the problem with stress urinary incontinence and mesh was not the issue. The issue was cystoceles, or herniated bladders that were coming out through the vagina, and using mesh to put those back up. That's where the problem was. It wasn't with the stress. So that's still a good procedure. But now there's a procedure called Bulkamid. And Bulkamid is like putting a washer in. So you have your urethra, and the urine's going to come out here. So right about here, you've got your sphincter muscle. That's the pelvic floor. So this is only about maybe 1.5 inches, 2 inches of length here we're talking. So if I look in here with a telescope, I can see the sphincter, and I want to be somewhere in the mid-gland here. And what I do is I do a little injection. I push the needle in like that. And by doing that, I'm allowed to inject a substance that's not going to cause you any problems, that will basically cause this to bump out. And then I'm going to do it at all 4 quadrants. So I'm going to do it at 10 and 2. I'm going to do it at 5 and 7. So I do this here, and then if I was to do it there, then the other one's here. And so basically that causes a small obstruction, but that allows you to be dry. So you may not go to 100% dry, but if you're somebody that's, every time you're moving around, you're leaking urine, you can't go to the gym here, you can't do any of those things because you leak, this will allow you to do that. And it's done under IV sedation. It takes 10 minutes to do. It's not a big procedure at all. If there's any problem with trying to urinate and you can't urinate afterwards, basically you pass a little catheter up here, and that allows it to open up a little bit, and you're fine. So that's another great procedure that people should consider if you have that problem. So let me open it up to questions for you folks. God, I did a good job.
Don't say it.
I said he did a good job.
Well, thank you very much. I appreciate that.
I'm just at the beginning of some of this, and as a teacher, it can be awkward.
Yes.
It gives the students something to look forward to when I have to run out of the room. But are there any other short-term fixes or even medications that you would recommend?
We're talking probably about a prostate problem, correct? Yeah, so you can take alpha blockers, you can take Flomax. I always start every patient I see on Flomax and see how they do with it. Some people do great, some people not so much. The side effects for Flomax typically are going to be feeling tired and feeling dizzy, and some people have headaches with it. Those are the things that primarily people complain of. Mostly the fatigue is the biggest one that people complain about. But that doesn't happen to everybody. That just happens to some people. So definitely the first place to start is with medication, and just to make it clear, basically Medicare is not going to allow a lot of these procedures to be done unless you try medical management first. So we always start with medical management.
I don't have a question, but I know listening to this speech that you gave, you think that this only was for men that have BPH and that sort of thing. There are a lot of women as they get older having trouble with leakage.
Well, that's why we discussed this right here. Yeah, so basically urge and stress incontinence. Our urge is primarily with medications like mirabetrol, Detrol, oxybutynin. They all have their own different side effect profile. It works for some people. Mirabetrol would be the one I would suggest. It has the least amount of complications. Unfortunately, it's the most expensive one. But some people's insurance covers that one. So mirabetrol for urgency, running around, you can't get to the bathroom in time, urgency definitely. And then if the problem is you're picking up your grandkids and you leak, then I would suggest Bulkamed and just tightening up the urethra so that it doesn't leak on you. So that was the purpose of that, was to realize that women have problems too.
Regarding the BPH, is there ever a situation when the prostate is too large that you can't do that urologist
Yes,
procedure?
definitely.
Yeah, I have an elderly friend who has a problem. He's in the bathroom for like an hour. What did he? It's only because he's trying to go, or is he trying to get some privacy? I don't know. But I wondered about that. And then is there ever, with any of these procedures, this diagnosis, do you have a problem with incontinence?
Generally not, no.
Okay, because my father-in-law, many years ago, and he had cancer of
Right.
the prostate.
Yeah, okay.
But they removed it. I don't know whether they removed all of it or 3/4 of it or what they did, but he was very incontinent.
Yeah, looking at cancer of the prostate, it's probably a 20% chance or so that you're going to have leakage afterwards. And then if you want it, then depending on the studies you look at, some people say on some of the studies, well, you're not really having leakage if you only use one pad. So they sort of change it a little bit and say, oh, this procedure does a little bit better. But it's usually 20%, and then there's going to be another 15% or something that still need to wear a thin pad because they're chopping wood or something. You get a little bit of leakage. But that's pretty much the story with prostate cancer.
Okay, and regarding female incontinence, does constipation
Plays a role, yes.
plays a role in causing it? So if you relieve some of the constipation, maybe you would leak.
Correct, yep. And remember I told you that both the bowel and the bladder share the same nerve. So if something's going on one side, the other side sees it. So you can get some problems with that just because they're innervated by the same nerve. And if the feedback is the same. But going back to your question though about is it too big for the urolift? Some people definitely are. That's why it's been great that we've been able to purchase the aqua ablation machine, because that'll do any size prostate. I've been doing the urolift procedure for, I don't know, 3-4 years, something like that. I've done over, it's been around longer than I've been doing it. So I had the same problem, because before I went to Europe, before I went to Florida, I was here. I was in Springfield area. And my dad's a urologist, my brother's a urologist. So I had a practice there. And just like I was saying before, people weren't interested in me doing urolifts. Massachusetts is so conservative. So I went to Florida, all of a sudden everybody wanted one. So it was a totally different mindset down there, as I guess I was trying to point out.
It's a very liberal in Massachusetts, though.
Yep, true enough. Let's not get into that discussion. Yeah, so that's the reason why. So when I went down there, I started doing a lot of it. It works great. Like I said, we're going to become the only center of excellence for this procedure in Massachusetts. I've got a lot of experience with it, and it works great for the right size prostate. It's sort of like if you think about a carpenter doesn't only have one hammer. He might have a sledgehammer, he might have a finished nailer, he may have a roofing hammer. So the same thing happens when you start treating patients. You can't look at them and say, one hammer is going to fit this problem, and bang. So when you're a hammer, everything's a nail, right? So it's not the same problem. So you got to be able to treat things independently and look at the different procedures and allow you to do what you need to do to help the patient and maximize the benefit. So that's what I do. That's why I don't just have one thing that I can do for you. I have multiple things that I can do for you to try to get you to where you want to go with the amount of side effects you're willing to accept and the best value for you. All right, well listen, thank you all for coming tonight. I really appreciate it. I have some cards on the back table there. There's some pamphlets if you want to take them. There's also a pad of paper back there if you want to write your name and phone number and want my office to call you about coming in and seeing me. Be happy to do that. Okay? Thank you.